Good evening, everyone. It's my genuine pleasure to welcome you to this webinar. Our speaker, Dr. Sam Schulman, really doesn't need much introduction. You are probably familiar with him for his seminal work on the duration of anticoagulation papers that were published in the New England Journal of Medicine, and then more recently on treatment of acute VTE with the newer directional oral anticoagulants. Dr. Schulman, as a hematologist, also has an interest in terms of bleeding, in terms of bleed management, and that will be the focus of this discussion today. And, of course, he's a professor of medicine here at McMaster University. So my role is really only to help guide some of the discussion. You will see on your webinar up on the top right-hand corner, there's a little shout-out box that has a chat function. So if you want to put in a question during the course of the presentation or a comment, please do so. If I think it's really important that we address it right then and there, we will. Otherwise, we will address some of the questions to Dr. Schulman, and I might pipe in perhaps as well during the end of the presentation. So we should be wrapping up by 5 minutes to 8 or shortly close to that. Once again, please, if you are in an environment where there may be background noise, please mute your line. You can press the *6 function, and that should mute you, and you can carry on with other things, but it just makes things a lot easier for the speaker and, of course, for our audience. So we have, I think, over 35 members, and you can see some of them are identified, others are not. And once again, I'd like to welcome you all to this evening's webinar on behalf of Thrombosis Canada, and again, acknowledge the support from our Octa Pharma. So at this juncture, I'm going to turn it over to Sam, and I know there might be some people coming on to the call, and we'll manage with that. But without further ado, Sam, I'm passing the baton over to you.
Thank you, Jim. Thanks so much for having me at the Thrombosis Canada webinar. And thank you to all colleagues and friends who have taken busy evening time to participate. So we will address the topic of 4-factor PCC for management of 10A inhibitor-associated major bleeds. First of all, my disclosures, and you will note that I have received research grants from Octa Pharma, and the study that will be presented here was funded by the unrestricted grant from Octa Pharma. I will split the presentation into 3 main areas. The first, review, which will include preclinical data on reversal of 10A inhibitors with PCC. Thereafter, I'll share with you some of the recent data from the cohort studies, and finally, compare PCC and andexanet alpha data for reversal of anticoagulation by 10A inhibitors, and discuss some open questions and a little bit of a look into the future also. So, all of you probably well familiar with the fact that PCC is useful and recommended for the management of warfarin-associated major bleeds, and we have had that available in Canada, approved for about 10 years. And a lot of data have come from studies by Ravi Sarod and his group, the K-Centra study with 4-factor PCC versus plasma in 202 warfarin-treated patients who had major bleeds. Most of those were gastrointestinal bleeding and not so many intracranial hemorrhages. And the main outcome here in this study was reversal of prolonged INR. So you can see that 4-factor PCC immediately reversed INR compared to plasma. They had as secondary outcomes effective hemostasis, and this is interesting. They used for the effective hemostasis assessment guide that they had discussed with FDA, and it was 3 options: good, moderate, or poor, and we will talk about that later on. So they had 72% effective hemostasis with 4-factor PCC versus 65 with FFP, and this was not statistically significant difference. They also looked at fluid overload, and although numerically 4.9% versus 12.8% looks good, the numbers were small, and it was not statistically significant either. Another study specifically for patients with warfarin-associated intracranial hemorrhage was conducted by Thorsten Steiner, presented in The Lancet 2 years ago. And after recruiting 54 patients, which took them 5.5 years, they prematurely discontinued, and this was because of claimed safety issue. And the safety issue was that hematoma expansion was significantly larger in the FFP group, 23.7 ml versus 9.7 ml in the PCC group. There was also a numerical difference in deaths, but that was not statistically significant. There was no difference in the clinical outcome regarding modified ranking scale score or thromboembolism. This shows in this INCH trial the hematoma expansion, so the volume of the hematoma with PCC patients in blue and FFP patients in pink, and then at 3 hours there was this greater expansion in the FFP group that became statistically significant. Katri Chayak-Adisaksopa, who was a fellow, a scholar with us for a few years and produced many good systematic reviews, also looked at the PCC versus FFP and managed to dig out 13 randomized clinical trials and 8 observational studies, and by adding them all up and analyzing, meta-analyzing, he could show that there was, with PCC versus FFP, a significant reduction in all-cause mortality as well as in volume overload, no difference in red cell transfusion or thromboembolism. And already before that, in 2012, the ACCP guidelines recommend, or rather suggested, that PCC should be used instead of FFP for major bleeds on warfarin. So enough about warfarin, but it could be reasoned that if it works for warfarin that lowers coagulation factors, including factor 10, then maybe PCC would be useful with specific 10A inhibitor-associated bleeding. And we will talk a little bit about animal models and human volunteer studies. So first, some animal models on top here, and there have been a good number of studies, more than these, but these are examples here at the top 3 with different animals, rats, mice, and rabbits, and then ex vivo or in vitro studies with human plasma. Also, all of them essentially going in the same direction, showing an increase of the endogenous thrombin potential and shortening of the prothrombin time in almost all the studies. Only 2 studies looked at actual bleeding, and there was a decrease in bleeding in a rat model and intracranial hemorrhage that was caused by inducing trauma to these mice, so hematoma volume was decreased with PCC in these compared to control. Now, if we look at human volunteers that were fed rivaroxaban, apixaban, or edoxaban, then we again see they were tested with the same lab parameters, an improvement, increase of the endogenous thrombin potential, which to begin with, when you give rivaroxaban, apixaban, or edoxaban, the endogenous potential is decreased, and then it's increased back to or almost back to normal with PCC, and the prothrombin time is shortened. They did not subject these human volunteers to trauma except in the edoxaban study where they suffered punch biopsies and had to, well, it was measured how long it took and to normalize or stop the bleeding and the volume. So there was normalization with PCC, but not with the 10 units per kilo. So that was the lowest dose tested in any of the studies, 10 units. And you will notice that in some studies they used 50 units per kilo, and in this study they had 3 different doses, 10, 25, and 50. Now, typically when they gave 50, the volunteers had first had a little bit bigger than the usual therapeutic dose, so rivaroxaban 20 milligrams twice daily, or apixaban 10 milligrams twice daily, to keep in mind. We then saw some small case series published by Bayer Westendorf from the Dresden registry, where there were many major bleeds, but he could filter out 6 with rivaroxaban, and 2 other small case series. And just recently, there was a much larger retrospective case series for urinary intracranial hemorrhage, all of them, 94 patients, and 65% did not have a hematoma expansion, and they got either 2,000 or 2,400 units. So that depended on if they were treated, if they had been on rivaroxaban, they got 2,000, and if they had received apixaban, they got 2,400 units PCC. So we started planning 3-4 years ago in Canada the UPRATE study with PCC for management of anti-10A, oral anti-10A inhibitor-associated bleeds, and then I got my old colleagues in Sweden to also be involved. And we planned this initially as twin studies with the same protocol, but then because of regulatory authorities in Sweden and some differences in infrastructure, they became slightly different. The Swedish study was published with the name UPRATE. We only use the name UPRATE internally here in Canada between the investigators. In both studies, we used ISTH major bleeds as inclusion criterion, and patients could be on rivaroxaban or apixaban when this happened. We excluded patients who had received other coagulation factor products like APCC or recombinant 7A, but this hardly occurred at all. So in Sweden, the infrastructure was different. So the clinics call a center in Stockholm and ask for advice, and then after recommendation, they give PCC. as opposed to that in Canada, we had hospital-based protocols that recommended a fixed dose of PCC already for several of the participating centers. And in Toronto, that joined halfway through the study, they had initially a body weight-based recommendation, but they agreed to use the fixed dose. We had a small difference that in Sweden, and that was the requirement from regulatory authority. They wanted leaner patients that weighed less than 65 kilo to get only 1,500 units, and the others got 2,000 units. And in Canada, it was just by protocol 2,000 units. So why did we use a fixed dose of prothrombin complex concentrate when you saw that in the human volunteer studies, it was typically a weight-based dose, 25 or 50 units per kilo? Well, it was a discussion between the steering committee members that were local PIs in this study initially, that the 10A inhibitor, rivaroxaban or apixaban, is given at a fixed dose. And probably then in lean persons, there will be higher concentration of the drug than in obese persons. And then the same for PCC if we give it at a fixed dose. Moreover, we felt that 2,000 units was very easy to remember and would be appealing to the ER physicians. For the effectiveness assessment, the original plan was to use the same assessment scale as the Thorough they used in the K-Centra study. But we had to modify it a little bit because our study is observational, so the patients are treated first and then we are contacted, or the research team is contacted, and for some timing purposes we had to modify, so we included also neurological symptoms and not only CT findings. But in Sweden they decided to, when the ISTH definition came after we had started the study, that they would use that instead as a primary outcome, whereas we in Canada used it as a post hoc assessment. And then we used another set of criteria, the ones that were in the Annexa 4 study with andexanet alpha, also for a post hoc assessment of intracranial bleeds, to be able to compare with the Annexa 4 study. The Swedish study, they screened 92 patients and 84 were included and analyzed, recruited from 25 sites. And you'll see that the median or mean age is very similar in the studies, the Swedish and the Canadian, 75 years here, 64% male, mainly patients with atrial fibrillation, and a preponderance for rivaroxaban. And in Canada, where we screened 71 patients and 66 were included and analyzed at 9 sites, again, you see age 76.9, 67% males, and mostly atrial fibrillation, and the same distribution, rivaroxaban and apixaban. The types of bleeds in these studies were actually dominated by intracranial bleeds as opposed to the K-Centra study. So 55% in Canada and 70% of the patients in Sweden. And second came gastrointestinal bleeds, 24% here and 16% in Sweden, and then there were few of other types. There were 30+% that were trauma-related bleeds, and Then if we go down to, we also showed from Canada the time from onset of bleeding to the time they received PCC, which was 8.6 hours median. But most concerning actually is that the time from arrival to the ER until they get PCC was 5.4 hours with us and 6 hours in Sweden. And this is admittedly too long, and especially for intracranial bleeds, we will have to look into how to improve this and do it faster. The first dose of PCC, so they could give a second dose, which was done very rarely in 3 cases in Canada. But the first dose was almost exactly 2,000 units, but there were some protocol deviations. And in units per kilo, it became 26.4 and 26.7 units per kilo in the 2 studies. So the effectiveness, as we assessed in Canada according to the modified K-Centra assessment guide, was that we had overall good effect in 65%, moderate in 20%, and poor in 15%. And then when we look separately at the intracranial bleeds, you will see that it's the same distribution, and gastrointestinal bleeds also essentially the same distribution. So it didn't seem to matter where the patient was bleeding. Then for comparison, as I said, we use the post-hoc, the ISTH definition, which is binary, effective or ineffective. And this was done centrally with us and independently centrally in Sweden. And you can see that we arrived at almost exactly the same results, 69 and 68% effective. Now, we can look also at the comparison of PCC versus andexanet alpha for intracranial hemorrhages specifically, because there the Annexa 4 study used the hematoma expansion. So that was available from our studies CTs as well, and they graded them. If it was less than 20% expansion, that was classified as, in their words, excellent, and then 20 to 35% expansion was classified as good, and more than 35% expansion as poor. So you can say what you want about calling up to 20% expansion excellent, but never mind, if we just look at the numbers, so we can see that there is very minimal difference between the 2 studies. And so there were, in the andexanet alpha study, 20 of the 47 evaluable patients, 20 had intracranial bleeds, and we had 33 with intracranial bleeds. So those are the denominators for this calculation. So, of course, not very large numbers of patients with intracranial bleeds, but quite similar results here that give some food for thought what actually is going on. On the other hand, the thromboembolic complications, you can see that in the K-Centra study with FFP 6%, that's against vitamin K antagonist, and with PCC 8%, and for us in Sweden 4%, and in Canada 8%. So pretty similar. And then the andexanet alpha study as presented in the New England Journal paper, 18%, although in the an oral presentation earlier this year when they had larger numbers. It had gone down to 12%. So why is there a difference? Can we explain it by more aggressive resumption of anticoagulation in our studies? So I don't think that that's the whole explanation, because in Annexa 4, within the first month, 27% had been resumed. In the Swedish study, 32%, and in Canada, 62% had been resumed on either prophylactic or therapeutic dose anticoagulation. So, I mean, between Annexa 4 and Sweden, it's a rather small difference from 27 to 32. And the bigger difference is between Sweden and Canada, and still with more aggressive resumption in Canada, but the thromboembolic events seem to be numerically lower in Sweden than in Canada. So I don't think that is the whole explanation. Now, some questions are left open. Whenever you study something, you try to answer one question, but you get many more questions unanswered, and that's typical. So the optimal dose of prothrombin complex concentrate, so we ended up using 2,000 units corresponding to about 25 units per kilo. And it's very difficult, and we knew that in the study by Ehrenberg that was published in Circulation 5 years ago, the first study in human volunteers with PCC against rivaroxaban, they used 50 units per kilo. But those were healthy volunteers, and we have sick patients who are on an anticoagulant that we're stopping, and they're bleeding, and they have an underlying prothrombotic disorder. So we felt that 50 units per kilo is risky from the point of view of thrombosis, and therefore we went for 25. And of course, the reversal of the ETP from the human volunteer studies, that it was partial with 25 units per kilo, but this is a surrogate marker and doesn't tell us exactly what's going to happen in a bleeding patient. And these volunteers received higher doses of rivaroxaban than we give our patients. Of course, it would be interesting to study a higher dose of PCC than 25 units per kilo to know if you can get further efficacy or not, but that's not in the plan right now. The question is how much better we can do. So, as I mentioned, we had in the two studies, according to ISTH definition, 68 to 69% effectiveness. But yes, we would like to reach 80 to 90%. But we must remember that a majority of the patients in these studies were intracranial hemorrhages. And it's not going to help to give more PCC if we give it too late. So the brain damage is already done. So maybe we have to work more on giving it earlier, acting faster than to increase the dose. And for gastric bleeds, they can be arterial, and an artery will not stop bleeding with the injection of an intravenous drug. They'll have to go in endoscopically and put on a hemoclip or cauterize or inject adrenaline locally. So we're not going to reach 90 to 100%, whatever we do with just PCC. And then you can ask also, are there other factors we have to take into account? If the patient is on concomitant antiplatelet therapy, should we give platelets at the same time? If the patient has a renal failure, is that going to result in less effectiveness, and do we need to give more, higher dose to those patients because they can have been accumulating the 10A inhibitor in the circulation. And another question is, would we get better results if we added tranexamic acid or if we use, in addition, local hemostatic agents? And we will try and look into that when we have more patients accumulated into subsets and see if we can tease out if any of these have an importance. We're not ready to answer those questions yet. And another question is thromboembolism that we see in all these studies, is it caused by the PCC? And I believe that many of my colleagues and I, we think that the main problem is that we are interrupting anticoagulation, and we know that when we interrupt it for surgery, for instance, there is a risk of thromboembolism. We know that when a patient bleeds, there is an activation of the hemostatic system, and that's physiological. I mean, we have to do it in order to form clots where it's bleeding. Then, of course, we see that the treating physicians are hesitant to resume anticoagulation afterwards, and maybe they're waiting longer than they should. So 4 to 8% that we saw of thromboembolism in the upright studies, maybe we could reduce it with a bit more aggressive resumption of anticoagulation, but we know also that if we do too early an intracranial hemorrhage, we get rebleeds. And whether the protein C or protein S that are antithrombotic, and they are present in the PCC, how much they help or what role they have, it's hard to tell, really. The question keeps coming back if we should have really given a fixed dose or if we should have adjusted it by body weight. And I told you the reasoning why we gave the fixed dose, 2,000 units, and also that it was easy to remember. However, the PK studies that have emerged and have been done with the 3 10A inhibitors that are approved here have shown that different PK parameters such as area under the curve for rivaroxaban or volume of distribution for apixaban or renal clearance for edoxaban, they are not or very minimally affected by the body weight. So maybe our assumption was wrong, and it seems like obese patients have about the same level of apixaban or rivaroxaban in plasma as normal weight patients. So what's next? Well, a common question is, can we also use PCC for patients who are not bleeding, who are on these drugs and need emergency surgery, surgery that cannot wait 8 hours or more until the body clears a good proportion of the drug? And then another question is, of course, would the regulatory authorities agree to expand the current indication for PCC, 4-factor PCC, that now is approved for management of warfarin-associated bleeds to also 10A-associated bleeds, and or what additional studies would they require? But to address the first question first about emergency surgery, so in a retrospective chart review from our hospital, where we received from transfusion medicine a list of all the patients who had received PCC, 247 patients, and it turned out that of those, during that time period, 21 were on a 10A inhibitor and had an emergency surgery or procedure done within hours after receiving PCC. So luckily for most of them, there was an assessment of hemostasis by the surgeon in the OR report or in some additional documentation. And if there wasn't, we approached the surgeon with the case and asked them retrospectively to make this assessment. And Siavash Pilan has presented these results and published them in Journal of Thrombosis and Thrombolysis. So these 21 patients, again, similar age, mean age of 74, as you can notice, and again, a bit more rivaroxaban and apixaban, and of course, mainly atrial fibrillation. And some of them were on antiplatelets also. So the outcomes, 18 were assessed as completely normal hemostasis by the surgeon, and 3 as slightly abnormal. So then there were a couple that had were assessed actually as more abnormal, but due to technical difficulties, they tried there to put an endograft into the aorta and couldn't fit it, so the patient continued to bleed from an aneurysm, and of course PCC is not going to help against that. The drop in hemoglobin was 15 gram per liter over the surgical period, and corrected for blood that was given was 21 gram per liter, and estimated blood loss a median 200 ml. 6 patients died, and 4 of them had intracranial hemorrhage, and that was tried to be alleviated by a twist drill, but they died from their intracranial hemorrhage because it was too large or too late to do anything about it. One had, sorry for the spelling mistake, hydrocephalus with brain herniation and died from that, and one had intra-abdominal bleeding that was unstoppable compartment syndrome. They tried with also endovascular embolization from the bleeding vessels, but could not get it to stop bleeding. There were limitations. This is a retrospective analysis with all its problems. Anti-10A levels had only been done in 2 of the 21 patients. Timing of the last dose of anti-10A was not always known. And, of course, we don't know if the patients were selected somehow, if most severe cases did not receive PCC or were not operated on at all. So it's important to do a prospective study, which we are planning now, together with some convector sites, the proxy study, and we just received provisional approval from Research Ethics Board in Hamilton. Some minor questions have to be answered. This will be a prospective pilot cohort study for 20 patients, and it's supported by Octa Pharma with an unrestricted grant. The emergency surgery has to be a surgery that will result expectedly in at least 50 ml of blood loss, so that we're talking about some measurable blood loss that we can compare with. And we will need anti-10A levels, so that they can be, of course, obtained retrospectively if we know the patient is already in surgery. Typically, they have had an INR done before surgery, and from that test tube, if it's still available, anti-10A should be analyzed, but we will only analyze for effectiveness dose where there is an anti-10A level available. And that should be at least 75 nanogram per ml in level, and that is the same as is used in the Annexa 4 studies to qualify the patients for efficacy evaluation. The dose will be 2,000 units per PCC, and at least in Hamilton and I believe in some other places in Canada, it is already in hospital protocol, not only for major bleeds, but also for emergency surgery in non-bleeding patients. So, ladies and gentlemen, we have looked at data from animal models and human volunteers that lend support for effectiveness of PCC in this context, the management of 10A inhibitor-associated bleeds. We have seen the results from 2 prospective cohort studies and additional case use that seem to indicate effectiveness, but we must admit that the level of evidence remains low because we do not have a comparator in these studies. And actually, that is the same for the antidote studies, for the idarucizumab and andexanet alpha studies. There is no comparator in these published data. The prevention of bleeding in emergency surgery could add some evidence because if the patient has clinically important levels of rivaroxaban or apixaban, is given PCC and has normal hemostasis, that should give support that we have at least a general pro-hemostatic effect. It's really not a direct reversal of the 10A inhibitor. It's not a specific antidote. It's rather a pro-hemostatic effect by giving factor 2, 7, 9, and 10. Thank you.
Thank you very much, Sam, for that very elegant and comprehensive presentation. So we have about 10 minutes or so left, and for the members that are in the audience, if you can ask Sam a question or provide a comment for some feedback, and you can do that just by, again, going to your chat line and typing in your comment or question, and I'll direct it to Sam. If you want to speak to Sam directly, perhaps you can, just state your name in the chat line, and I can identify you, since that way we won't have, multiple people talking at the same time. So feel free to ask any questions, again, using the chat line function. Sam, maybe I can start us off and ask you about the dosing issue, because this seems to come up a lot. And you mentioned in the studies you sort of opted for simplicity of a standard dose versus a weight-based dose. And my question was that depending on what study you may look at or review, the dose regimen has been as low as maybe 20 units per kg to as high as 50 units per kg. And do you think we're still searching for that sweet spot in terms of the dose that will be effective but minimize potential thromboembolism, or do you think that a fixed dose approach that we have right now with, I think you mentioned 2,000 units is the way to go?
I think that for bleeding patients, maybe we should rethink that it should be weight-based, because the level of the 10A inhibitor is similar in obese and non-obese patients, but the PCC will be distributed in a larger plasma volume. So I know that there are plans to start a study with octaplex for major bleeds, where probably a weight-based dose of 25 units per kilo, which means that obese patients will get more, to see if that works better. Having said that, I mean, we need to analyze further the Swedish and the Canadian study to see, did we have a different results in lean versus obese patients, and to understand, does it mean, is it important to dose it per weight, or does it maybe not matter at all?
And so what would be your minimum and maximum dose that you would administer, let's say, for somebody who's having a life-threatening intracranial or GI bleed?
I think that the sweet spot is somewhere between 25 and 35, 37 units per kilo. I would be worried about going up to 50 units per kilo. I think that we could end up with more thrombotic events then.
And just on that point about thrombotic events, this is something that I've heard a lot from clinicians, that there is some concern about using PCCs and the potential for thrombosis. And I know that in a previous meta-analysis, rates of thrombosis were kind of in the 2 to 4% range, yet in the data that you presented, they appear to be a lot higher. And do you think that is because of the patient population study, the lack of reintroduction of anticoagulation? And of course, these are not comparisons, but can you provide some views about your views about the thrombotic risk associated with PCC administration?
I think the slightly higher numbers in these uprate studies is because we had a lot of intracranial bleeds. So with that comes, of course, hemiparesis, hemiplegia, and also release of tissue factor from the brain, and probably even more of a hypercoagulability than perhaps gastrointestinal bleeding.
Okay. And once again, if anyone has a question, if you want to shout it out, please go ahead, or once again type it into the chat line. Sam, one thing just to provide a broader sort of view of things, do you think that based on what you've talked to us about tonight, that there's any role for using fresh frozen plasma for patients who are having serious bleeding and are anticoagulated? Is there any role for FFP?
Only if we suspect that there is a more general coagulopathy, that it's not only the 10A inhibitor or warfarin or whatever that is the culprit, but that, for instance, the patient is developing DIC, then I think that they need more broad spectrum. They need other coagulation factors.
And I think my final question would be, would you adjust the dose of PCC based on what you think is the residual anticoagulation left at the time of presentation, or would you adjust the dose, for example, based on laboratory coagulation tests?
If we can get the specific anti-10A levels fast enough, I would base it on that, but I don't think that's within reach the next few years yet. We have to wait too long to base our, and especially for intracranial bleeding, we just have to give something quickly. So, and to guess based on their assumed creatinine clearance, and it's hard. Often we don't even know when exactly they took the last dose. The patients are very sick. They don't give correct information regarding their last dose of rivaroxaban, apixaban. So it would be interesting to do a study where experts assess the where they think the level is, and then compare with actual levels obtained from the lab.
Okay. Well, so what I'm hearing, I think, is that we've identified, as you say, the population that we want to consider use this regimen between 25 and maybe 35 units per kg, and to consider weight-based, not just fixed dosing, and that the thrombosis risk may be a consequence more of the clinical milieu than the actual administration of these clotting factor concentrates, and that if we shouldn't be reliant on laboratory tests or in some cases patient history to judge whether there is a residual anticoagulant effect. So that's very helpful information. For those of you out there that may not be familiar with Thrombosis Canada, there is a clinical guide as well as a clinical tool that will help assist you in the management of patients who have anticoagulant-associated bleeding, whether they're on a vitamin K antagonist or a direct oral anticoagulant. So I'd urge you to have a look at that and provide us with any feedback that you have. I'm not seeing any other questions. Sam, it looks like you covered it all. So once again, thank you for this nicely laid out presentation. Thanks to all you in the audience that were able to take a bit of time from your evening to participate. Thank you also to Octapharma for their unrestricted educational grant.